Welcome to the American Shoulder and Elbow Surgeons Podcast. I'm your host, Peter Chalmers, a shoulder and elbow surgeon at the University of Utah in Salt Lake City. Before we get started, I should mention the views expressed in this podcast do not necessarily reflect the views of the American Shoulder and Elbow Surgeons Society, the University of Utah, or the institutions of any of our guests. Okay, today we have an episode for you reviewing the best of the best from the Journal of Shoulder and Elbow Surgery from 2022. We've asked Dr. Bill Mallon to pick his favorite articles, and then we've invited the authors on to discuss their work. So first off, I'm here with Dr. Patrick Curtin from the University of Massachusetts in Worcester. And we're here, I'm sorry if I'm pronouncing it, would you say Worcester, Worcester? I'm not from
It's
Massachusetts
Worcester.
originally.
Yeah, no,
Worcester,
yeah.
Worcester.
You know you're from Massachusetts if you pronounce it not the way it's spelled. It's no one ever says any of the towns the way they actually look, but yeah, it's Worcester.
So he's here with us from Worcester, which has multiple extra letters in its spelling, but it from the University of Massachusetts. He discussed this article entitled "Morbidity and Mortality of Fragility Proximal Humerus Fractures: A Retrospective Cohort Study of Patients Presenting to a Level 1 Trauma Center." Dr. Curtin, welcome to the podcast.
Thank you so much. This is a great opportunity. I really appreciate it.
All right, so tell us what inspired you to do this study.
So at our institution, we have one research resident a year, and so that's me. And I was trying to find some projects that were things that I could do and kind of pick up and start on my own. And we have this really good internal database looking at kind of all the consults and things that we see. And because of that, we have some good data in our system kind of looking and pouring through some of the patient charts. And one of my experiences as a med student was at Boston Medical Center, and they have like a really big, strong geriatrics department and program. And that left a lasting impression on me, kind of talking about how, falls aren't necessarily, like that's not like the diagnosis. It would be like fall because they tripped on their throw rug, or fall because they didn't use their, ambulation aid, or fall because they have peripheral neuropathy due to their diabetes. And so that kind of prompted me to start looking at some of these fragility fractures and try to figure out, are we doing the right thing for these people, or are they kind of falling through the cracks? Because it felt anecdotally to me that we were kind of missing the mark a little bit on some of these fragility fractures. And so a good place to start was looking at some of these fragility proximal humerus fractures.
All right, so you've got your database, you've got your year to do your research. Tell us how you did this study.
Yeah, so we ended up pulling all of the proximal humerus fractures from our database. So we had everything kind of loosely by AO classification, and so it makes it easy to pull out all the fractures, all the proximal humeruses, whatever it is that we're kind of looking at, and then we can kind of fine tune it. Then to make sure we weren't missing stuff, we also kind of pulled through our billing codes and other things and follow up just to make sure we weren't missing anybody. And from there, we started looking at mechanism. So I really wanted to make sure that we were talking about the population of interest. So really being specific that it, wasn't just you were older and had a proximal humerus fracture. You really had to be, a fall from standing, which we defined as a mechanical fall as like less than 5 feet, just for definition purposes. But really, they were all falls from standing, and kind of weeding out everybody else. So probably about half of our proximal humerus fractures were the more high energy fall from flight of stairs, fall, from height or MBC or motorcycle. But that left the remaining 279 females, 100 males for 379 patients that we had for our study.
So it's a big sample size. It sounds like you looked at a lot of data for them. What did you find?
So we looked at a lot of the things that we thought might be related, as well as just trying to pull out as much we could about their medical history and events. So the Charleston Comorbidity Index was a good indicator for overall health. We also try to look at that within kind of the sub-parameters of the Charleston Comorbidity Index. So that's kind of a verified way that a lot of orthopedic and other studies will look at how sick people is and what their general medical comorbidities are. That also takes into account age, but we also then factored that out and did it without age. We looked at other things that we thought might be influencing. So the ability for people to get around without an ambulation aid, or do they need a cane or a walker? Are they living independently, or are they already in a nursing facility or an assisted living? Their handedness, trying to see if in relationship to their injury, if the side of the injury, if it's contralateral, ipsilateral matters, as well as whether or not they got surgery and some of the other more treatment and follow-up parameters as well, and who they followed up with and for how long. So the orthopedic follow-up, as well as we also tried to look at whether or not they saw their primary care physician as well.
Now, reading through your study, it seems like the real headliner result is the 1-year mortality of 17%. So tell us, I mean, obviously that number it's a little bit lower than the 50% number usually presented with hip fractures. Why do you think those differ? What do you think, and do you think that's an age issue? Tell us what you think about how that number affects how we approach these patients.
Yeah, I will say that, not all these people are passing away. Obviously, 17% or so at a year. What we didn't publish, it was ended up being more like 24, 25% at 2 years. But there is a population. The one thing that we found was quote unquote protective was surgery, but we found that those were people who were otherwise pretty healthy. So it wasn't that surgery was protective or associated with lower mortality. I think just more these are healthy people, and then therefore they were getting either fixed or getting arthroplasty. But I think that 17%, what I glean from that is that that's much higher than I would have anticipated. I think for the hip fractures, we kind of have that beaten into us as an orthopedic population now, that's something that is associated with a high 1-year death rate, and it's not necessarily the surgery itself, although there is some risk for certain individuals, peri-op, but that 1-year mortality is because they have other medical things going on, whether it's COPD or unmanaged diabetes or heart failure, or they just are prone to falls. So looking at that same model and, sort of being like, it's not the hip fracture, it's the sign of, worse things to come potentially, is proximal humerus fractures similar in this population? I'd say what our data suggests is that it could be kind of a harbinger for things to come. And it certainly was a higher number than I was expecting. And I think that number also changed a lot of how I thought of it, counseling patients and talking to them, especially since a lot of these patients, at least initially, are non-operative.
Yeah, I think that's the really interesting thing to bring up is there a point at which we could intervene with some of these people and say, well, we know there's this mortality rate. Has that changed the way you've approached things in University of Massachusetts? Does it lead you to say, okay, these people, we need to make sure they're plugged in with primary care? Do we need to make sure that they're seeing someone to manage their overall health? How is that, do you think, going to change the way you approach these patients?
So I can speak personally to say the way it's changed how I approach these patients is, when I'm seeing people that have fragility proximal humerus fractures, I used to give the general feedback of, well, as long as it isn't a fracture dislocation or something with a neurovascular compromise, the kind of advice that I was giving in the emergency department as well, this isn't that big of a deal. The good news is for most people, this heals without surgery. It hurts a bit, but you can just have a sling and we'll see in follow-up, and, hopefully we can get you out of the emergency department, and kind of left it at that. And that's really changed now, kind of looking at these numbers. I'm much more thoughtful to try to figure out why they fell. Did they just lose their balance? Did they get pulled over? Did they, so there's a couple people that got pulled over by their pets that I've seen recently, dog walking on the ice and stuff. And then there's, other people that their peripheral neuropathy is causing them to lose their balance and they're falling a lot. So trying to suss that out a little bit, even if I don't get the answers, but enough to say, well, it sounds like you've had some falls before. I want to let you know that this is, really high risk that you could fall and break something else. And we could be talking about doing surgery for your hip, or, potentially you being much sicker back in the hospital. And so most people hear that. I think it's because, we, despite maybe this is my opinion, feeling like this is a injury that's not as big of a deal in the short term, and just trying to say, well, we'll see you in clinic. To them, that's a huge injury, and it might be the only time somebody's really talking to them, and so they remember a lot. And so kind of telling them then, like, what can we do to prevent falls, and them trying to internalize that at that point, I think actually might make a difference, although I don't have any data to support that yet. But I think that's kind of our next steps at UMass would be kind of looking at, are these people following up more? Are they kind of hearing what we're saying when we're changing our kind of verbiage around these consults? But the other big factor that we're focusing on, I think, as a specialty is the whole own the bone and trying to manage these osteoporotic fractures and just general bone health. And I think where at least our institution is really plugged in is around the hip fractures. So geriatric hip fractures, osteoporotic hip fractures, fragility hip fractures, whatever you want to call them, they end up getting plugged into our endocrinologists and see if they qualify for various bisphosphonates or other bone health care, or getting PTH and vitamin D and TSH and other kind of basic endo labs and seeing if there's anything that we can improve for them. And there have been some studies, I think mostly in the endocrine literature, although I think there is some in orthopedics as well, that kind of getting them tied into that improves mortality 90 days and 1 year for hip fractures. So I think the bigger institutional goal, which I think is just going to take a little bit due to the larger scale of it, but hopefully something I could take forward in my practice, would be getting people tied in for some of these other fractures. So proximal humerus fragility fractures, distal radiuses, maybe vertebral body compression fractures, some of these things that we know are associated with poor bone quality, and getting people tied in early.
I think that's really the main take home from the study, is that the mortality rate at 17% a year is probably higher than most orthopedic surgeons would guess. And that, again, we as surgeons may be the first people to see these people and to see these patients and give them maybe an opportunity to intervene. Now, you mentioned that the surgery, that there's a little bit of selection bias as to whether or not it influences mortality. And obviously this is not maybe the best study designed to assess that. But obviously there are other risk factors. The one that interested me the most is males. So if I understand correctly, males have a higher risk for mortality. Am I understanding the study correctly?
Yeah, that's what we saw. I don't know if I have a good reason why. It could be a little bit tied into that generally the male population in our group was also more sick, but I also tried looking at it with the, is it just males and females that are different? Is there like a higher Charlson comorbidity index, or is just a sicker population? But that's not the case. So there does seem to be something inherent with men, that they're either having a higher mortality for some reason that's not just they're also sicker. So that did strike me as kind of interesting. But again, are we a little underpowered or something? Maybe, who knows? But I think this is all, I'm hoping to just start a discussion around this. And I know that, some of these factors aren't necessarily perfect with the retrospective design, but at least kind of raising some concern and looking into some of these things a little bit more.
Yeah, I think that particular finding is very interesting. Osteoporosis is so common in postmenopausal females because of the hormonal changes. And males that develop osteoporosis, often there's a secondary, especially in their 60s and 70s, there may be a secondary cause. And I think that secondary cause is often also contributing to their mortality. So I personally thought that was kind of a nice take home to say, if you see a male with a fragility fracture in their 60s or 70s, you should pay attention, because that's probably a patient that is going to have there may be other things going on that you may or may not know about, and that patient may or may not know about.
Yeah,
so
I
like
think
that
that's
finding. I think that's a good one.
Yeah, I think that's a great point. That's something that certainly from poking up your antenna or just having like an awareness for, because certainly it's more common for women or females to have this injury, and like our study supports that too. 279 women compared to 100, but obviously there's a big mortality shift between that grouping, and subgroup analysis, and this gets a little dicey with the stats, but at least, like you said, it does raise some concern that there's some people out there that are certainly higher risk even within this high risk population.
Well, I want to congratulate you for study. Again, Dr. Mallon selected it, I think, because it's a relatively unique thing that I think is a valuable contribution to our literature. And we all see these patients in clinic, and I think having a better awareness for the association between this fracture and the patient's overall health is certainly helpful for all of us to keep in mind. So congratulations on your work, and thanks for coming on the podcast to discuss it.
Yeah, thank you so much. I really appreciate it. And I think that if nothing else, I hope the takeaway too is that it's not, for maybe the shoulder elbow surgeons, then it's the proximal humerus injuries, especially this fragility group. It's certainly a big takeaway. But also for just general orthopedics, like there are other injuries that certainly this could fall into, and you could apply a similar thought or study design, or even just quality improvement management within your own practice. I'll say that we're looking currently at similar study with like LC1 pelvis fractures and kind of the fragility fall from standing. And one of the big things that did change, and we might just be better powered for that, is that the big thing that was a protector and that actually decreased 1 year mortality and improved survival was follow up with their primary care within 3 months of injury. So I think, is that something we could see in our group if we expanded our numbers? Maybe it kind of trended that way without being statistically significant, but definitely a multi-team approach and multidisciplinary is certainly a great way to take care of all these patients.
So I'm here with Brandon Erickson of the Rothman Orthopedic Institute in New York, and he's here to discuss with us his paper, Is There a Difference in Outcomes Between the First and Second Surgical Procedures in Patients Who Have Bilateral Shoulder Operations? Brandon, welcome to the podcast.
Peter, thank you so much for having me on. Really appreciate you bringing me on.
Oh, it's my absolute pleasure to have you on. So tell us, this is a super interesting study. What was the impetus for you to do this study?
It's interesting. As we get further along in practice and you start to take care of patients that you've seen 5, 6, 7 years ago or even shorter, you start to notice that some of the problems that they have on one shoulder start to creep up on the other shoulder. And we always talk about, bilateral knee surgeries, hip surgeries, things like that. But I didn't really know how people perceive their first and second shoulder surgery and didn't know if their outcomes were any different between the first and the second one. Intuitively, you'd think that if somebody had a shoulder surgery and then came back for a surgery on the second side, that they were happy with their first side and that, presumably they wanted to go through it again. But it wasn't really clear how they performed, at least in the immediate postoperative period between the two different surgeries.
Okay, so you have this question about first, second surgery. Then tell us how you went about addressing this question. What study did you do to figure this out?
Yeah, so basically we took patients that were operated on by a single surgeon. So there were a bunch of Rubin Gabezis patients. It was done between March of 2013 and June of 2018. So we wanted to kind of get to the 2-year follow-up period. And then we took everybody that had surgery on both shoulders and we generated a list of CPT codes. And then we went through the list and matched them up based on what they had done on their one side versus the other side. And we wanted to find patients that had either bilateral arthroscopic procedures or bilateral open procedures. And once we narrowed that down, then we made sure that they had the same or at least a similar surgery on both sides. So we didn't want to match somebody that had a lateral J to somebody who had a total shoulder. We wanted to match a lateral J to a lateral J, total or reverse to total or reverse. And then from an arthroscopic perspective, we tried to match, biceps with biceps, rotator cuff with rotator cuff. We didn't want to match somebody that had, a distal clavicle excision to somebody that on the other side had a rotator cuff repair, if that makes sense.
Okay, so you got kind of the matched groups. And then what were the outcomes you looked at?
Exactly. So we did it pretty simply, actually. We just wanted to look at basically pain scores. And so we were looking at pain scores at multiple time points after surgery. So 2 weeks, 6 weeks, 3 months, 6 months, 1 year, and 2 years. And so this isn't a functional outcome study. This is just how did they feel? What was their pain level after the first versus the second surgery? And so
what did you find?
We also and the other thing we looked at, I should mention, we looked at, having surgery on the dominant side first or the non-dominant side first, and then going back to the other one. And basically what we found was that we had more patients that were in the open surgery group than the arthroscopic surgery group, just because it was easier to match, totals and reverses to totals and reverses without introducing a bunch of bias. And what we found was that, after both surgeries, patients did well. They, their VAS score decreased. But interestingly, in the first few visits after their second surgery, so at 2 weeks, 6 weeks, and 3 months after their first operation, they actually had higher pain scores than after their second surgery. So they did better from a pain perspective after their second surgery, but that difference kind of went away by the time they got to 6 months. So in the initial postoperative period, they tended to have less pain they reported less pain after their second surgery, but by the time they got out to 6 months and beyond, that difference went away. So saying that the initial postoperative period was slightly different, but the ultimate outcome was the same.
That's so interesting. Now, tell me why you think that is. Why is it that the second surgery patients have less pain than the first?
I think, it's interesting. When we go through our training, we get very familiar with the different types of surgeries that we do. We get very efficient at them. But every time a patient comes in for a surgery and it's their first time, let's say it's their first surgery they've ever had, it's very hard for them to know what to expect. And we make videos and we talk to them in the office, and our PAs talk to them and our assistants talk to them. And we try to lay out how the surgical procedure is going to go and how their postoperative recovery is going to go. But it really comes down to how each patient responds to that. And when they go through something, they have such a good idea of what to expect on the next surgery. Now, not to say that both surgeries are created equal, but generally the recovery period is relatively the same as long as there's not any dramatic differences with the surgery or anything that happened at surgery. And so I think that understanding what to expect is what really made them feel better after the second surgery. And it speaks to the point of, can we do a better job of explaining to patients what to expect when they go in for surgery, what their recovery should be like, how much pain they're going to have. I think that's something we, as an orthopedic community and a shoulder elbow community, can improve upon.
Fascinating. So how are you taking this into your own practice, Brandon? Like with this kind of new insight into first versus second, when you approach a patient now who's having the first surgery, how does this affect, like how do you go about it differently?
Yeah, I think I've tried to actually initially make some, patient, education videos about the common surgeries that I do. And I both talk to them in the office about it, and then I always refer them back to them so they can talk about it, or they can, watch the videos that I put out for them to try to better explain what they're going to go through. And then certainly for the second surgery, it takes much less time to do that, right? Because they already know what to expect. They already have an idea of what they're going to go through. So the surgical decision-making, the surgical discussion becomes 1/10 of the time that it was for that first surgery because they know what to expect.
Yeah, I think this is such a fascinating study. It's such a simple idea. And I certainly congratulate you guys for coming up with the idea and then executing upon it. So it's the thing that I think is so interesting about this idea is if you had polled orthopedic surgeons before this study, I'm not sure that everyone would have come up with this exact finding, but it's pretty robust. I mean, the p-values are quite significant. So it's, again, congratulations to you guys for your study. What's the next step? Where do you go from here?
Yeah, I mean, I think it is, to your point, it is a pretty simple study, honestly. And it's funny, going into it, I wasn't sure what we would see. I was almost a little bit worried that after the second surgery, they would have expected things to go easier than they did, because sometimes we misremember things after our first surgery. And I agree with you. I wasn't exactly sure what we were going to find, but I was actually kind of happy this is what we did find, because it makes me think that the patients who were certainly coming back for that second surgery were happy with the first one, but also we're happy with the second one and did very well from it. As far as, things moving forward, I think what we have to look at now is probably more functional outcome scores and seeing if patients do better from a functional perspective after their second surgery. And I think intuitively for me, I would think that after the second surgery, they actually may do better from a functional perspective because they'll be less timid about rehab and hurting themselves and things. But I could certainly see the opposite argument to that, saying that they did so well from the first one, they expect to do flawlessly on the second one. And if something goes wrong or they don't do quite as well, I could see them being much more irritated.
Well, certainly if patients are having more pain, then they should recover function more quickly. But I guess that's remained to be seen with your guys' next study. The other thing that I think is really, at least for me, I took from this study is I think one of the things we do when patients have pain is we tell them, look, this is temporary. You are going to feel better. It's going to take some time to feel better, but you're not going to feel the way you feel right now forever when the patient's in that acute period after surgery where they're really hurting. And I think that gets them out of that kind of catastrophizing pain mentality that can be this, negative cycle that leads to higher and higher pain scores.
You're exactly right. And the part of it is patients understanding what normal is, and everybody experiences pain so differently. And if you think about some of the, preoperative resiliency scores that are out there, obviously we know that people who tend to be more resilient do a little bit better afterwards and have lower pain scores. And so the question is, can you help somebody, or can you teach them to be a little more resilient before their surgery to help out with the pain? But I think that's probably a ways off.
Anyway, congratulations again to you and your group for the study, and we'll look forward to seeing the next steps, and I hope all is well in New York.
Thanks, Peter. Appreciate it.
I'm here with Dr. Nitin Jain of the University of Texas Southwestern in Dallas, who's here to discuss his paper, Risk Factors for Degenerative Symptomatic Rotator Cuff Tears, a Case Control Study. Dr. Jain, welcome to the podcast.
Thank you, Dr. Chalmers.
So this is a super interesting topic. Tell us what inspired you and your team to do this study.
Sure. What really inspired us is the fact that rotator cuff tears are so prevalent in the population in general. However, our understanding of really what causes them is still fairly rudimentary. So we had this very large cohort of patients, and that offered us an opportunity to look at what really are the risk factors that are associated with rotator cuff tears.
I mean, I think this is such an interesting topic for us as surgeons. All the time patients ask me this question, why did my rotator cuff tear? So I'm kudos to you for tackling this research question. So that's the impetus. Tell us, how did you do this study?
Sure. So again, as I mentioned, this is in patients that get atraumatic tears. So as you said, most of these patients are older adults who wonder why their rotator cuff tore. And the way we went about this, as you know, it's very challenging to be able to do such a study because there's just a whole host of factors that you can look at or variables that you can study as risk factors. And hence, you need a large enough sample size to be able to assess those risk factors with a certain amount of certainty or with enough power in your study. So we actually harnessed the power of big data in some ways. So Vanderbilt has a data repository that's essentially a de-identified version of the electronic medical record. This is called synthetic derivative. And it essentially gives us access to all of the patient's imaging details as well as their the entire electronic medical record. And so we still wanted to perform a gold standard analysis where we did not simply use the ICD-9 or billing codes because, as your audience knows, those are inaccurate sometimes. And hence, we actually looked at the patient's imaging. So we looked at the patient's MRI report, the MRI report or the operative report, and confirmed that the patient indeed has a rotator cuff tear if they were deemed to be a case. And to be a control, there needed to be structural evidence, either on MRI or through an operative report, that the patient's rotator cuff was intact. So we harnessed this big data, but really, did individual. It's harnessing the power of big data, but still not losing the precision of the diagnosis, because we actually went to each patient record and verified who are case and who are control. So in this way, we were able to get 2,738 patients in the study.
And I just want to make sure I understand. So the controls are patients who had shoulder pain, who underwent an MRI that showed that the rotator cuff was intact. So the controls are not normals. The controls are patients with shoulder pain.
That is accurate. The controls are patients with shoulder pain who have some other shoulder pathology, but their rotator cuff was intact on the MRI.
Okay, so now what did you find separating these two cohorts? The structurally intact rotator cuff versus the torn rotator cuff.
So eventually what we ended up with was 1,731 patients with rotator cuff tears and 1,007 patients without tears. And to your previous point, it would be the best control in this case, or in this situation, would be patients who have a shoulder MRI but are asymptomatic. But as you can imagine, that would be a very difficult study to do, and it would pretty much be not feasible. And therefore, we used the next best standard, which is patients who had some symptoms but had an intact cuff. We looked at about 30 variables or so that included all that had been previously reported to our knowledge. And these were mostly smaller studies that looked at usually only a limited number of factors. And so if their focus was on age, for example, they looked at age and assessed that age was related. So we took all of this prior evidence and studied all of the factors that could potentially be associated with rotator cuff tears, and added some variables that we thought were of clinical relevance. And eventually, after the statistical analysis was done, the factors that were identified to be associated with rotator cuff tears was advancing age. Now that is intuitive and very well documented. Male sex, a higher body mass index, a diagnosis of carpal tunnel syndrome. Those factors were associated with a higher risk of rotator cuff tears. And the ones that were associated with a lower risk included patients that had left shoulder symptoms, as well as depression and anxiety.
Okay, so I want to unpack that a little bit. So the age thing, I think, is something we all already knew. The higher prevalence in men thing is something we did not know. So explain to me, why do you think there's a higher prevalence of cuff tears in men than women?
Sure. And now this is, in some ways, what we are hypothesizing. We do not necessarily have evidence for mechanisms of why there would be a higher prevalence in males versus females. But in terms of hypothesis, one could hypothesize that especially in a lot of males, especially in blue-collar occupations, a lot of the workers tend to be male. And so there may be incidents of overuse of the shoulder, which eventually over time leads to a rotator cuff tear. There could be other factors as well, but that's what we would attribute this finding of higher prevalence of tears in males.
Certainly that fits with the BMI, where you could say maybe heavier arm, more work, but also BMI speaks to kind of a metabolic hypothesis. I mean, which do you think BMI is? What, A, B, or maybe both?
I believe it's both, actually. I find the finding of a higher BMI to be very interesting. And the reason I find it to be very interesting is that as compared with weight-bearing joints such as knee or the hip, where it's fairly intuitive that those patients with a higher BMI will have a higher risk of, for example, knee osteoarthritis, it is not so intuitive in shoulders, where shoulder is not really a weight-bearing joint. And although it is plausible that heavier shoulders may lead to a heavier, more load on the shoulder, it's not necessarily a direct relationship between the load on the joint or the load on the cuff and a higher BMI. So I find that to be very interesting. I actually think it is probably more of a biology, where the higher BMI, and this is also seen with fatty infiltration of the cuff. We are finding that with fatty infiltration as well, which is even more interesting, is a higher BMI leads to a higher incidence of fatty infiltration. And what I would hypothesize more is that there are intrinsic mechanisms in terms of either a metabolic syndrome or mechanistic changes in the cuff itself, in the tendon biology itself, that is leading to both a higher incidence of cuff tears, but also then eventually leads to fatty infiltration.
Okay, now tell us about the association with carpal tunnel syndrome. And one thought I had here is it may just be that some patients are more likely to come to the doctor, and those patients come with those complaints, because both these things are highly prevalent in the population. What do you think that is driving that association?
I would say the association with carpal tunnel syndrome is likely association, if one might call, by chance. Obviously, one could think that there is some sort of a biology that links carpal tunnel syndrome. The same biology that causes carpal tunnel syndrome may be causing rotator cuff tears. But I believe these are two inherently different issues, where the rotator cuff issue is really a tendon biology issue, whereas a carpal tunnel syndrome is more of a compression issue. And so I think this has more to do with the fact that these patients are already in the healthcare system, maybe potentially seeing an upper extremity surgeon who also has expertise in the shoulder, and these patients then end up having shoulder surgery because they have a rotator cuff tear as well. So that seems to be more plausible to me.
All right, and then obviously the last one here is there's this correlation. There's a lack of a correlation with depression. In particular, the patients who didn't have a rotator cuff tear were more likely to have depression. Now, I interpret this to mean that if you have shoulder pain and you don't have a rotator cuff tear, it's more likely that you're depressed. Is that's how, am I interpreting that correctly?
Yeah, that is accurate. And I think the reason for this is because our controls are not asymptomatic individuals. These are patients who have shoulder pain. So all this means is that patients who have other shoulder pathologies have a higher incidence of depression and anxiety versus patients that have rotator cuff tears.
Or, I mean, I think you could also use this to say, and I think everyone who treats shoulder pain in clinic knows this, that there are patients out there where maybe there's nothing we can find structurally, but who are certainly painful, and that some of that may be interpreted through the lens of mental illness.
Oh, absolutely. I mean, it is now very well documented that psychosocial issues have a huge relationship with musculoskeletal disorders and with pain. So this obviously has those same implications, and both patients with and without tears have a higher incidence of psychosocial comorbidities.
All right. So, I mean, I think what would be your take home here? I mean, what is how do you think this study affects our understanding of rotator cuff disease? Where do we go from here in terms of drilling down mechanistically on some of these correlations?
I would say this is really an initial step and a and a very robust data set in terms of being able to assess all of these factors, both in terms of giving us adequate power to the study and having more definitive answers to what really are the variables or factors associated with cuff tears. So from that perspective, I think this is an initial step. However, this study is still fairly superficial in the sense that it doesn't really explain the mechanisms or the biology of why each one of these factors, or some of them at least, are associated with cuff tears. So for example, the male sex as well as the higher body mass index, I find those to be extremely interesting, as well as advancing age. Again, as intuitive as advancing age is, it is not clear why only certain patients who are older actually have symptomatic rotator cuff tears. As we all know, a lot of patients with a structural deficit are still asymptomatic in terms of having rotator cuff tears. So what really causes, number one, what are the changes that are happening at a molecular level in the tendon that are resulting in advancing age to be associated with tears? And then secondly, what's causing patients to be symptomatic versus being asymptomatic, even if they may have a structural deficit? So I would say this really is an opening into further understanding what are the underlying mechanisms / biology. And I think eventually that's really the gateway for us to come up with better treatment options.
Well, I couldn't agree with you more. I mean, it's really interesting to me. One of the questions patients ask me routinely is they say, well, how could I have prevented this from happening? Or if I have a tear, how do I prevent it from getting larger? And there is nothing you can do to prevent it. And so things like this, I think, really give us the first steps towards developing preventive treatments. And additionally, as you mentioned, the first steps towards developing biologics to improve healing rates, which I think we all wish were higher. Well, I want to congratulate you on the study. I think it's a great first step. And as you mentioned, I think a robust analysis of really what sounds like a quite unique data set. And so congratulations on that. And thanks so much for coming on to our podcast to discuss it with us.
Well, thank you. Thank you for having me.
Okay, next up is Dr. Melissa Wright from MedStar Union Memorial in Baltimore. Melissa is here to discuss her study, an investigation into gender bias in the evaluation of orthopedic trainee arthroscopic skills. Melissa, welcome to the podcast.
Thank you. Thank you guys so much for having me. Excited to be here to talk about this paper and our study.
Well, I think this is going to be great. So let's start thinking. Tell us what inspired you to do this study.
Yeah, so, we have a monthly, if we're good about it, research meeting, and we usually have some residents, some students there. And it was just one of those things that kind of came up at one of those meetings. One of our former chief residents, she mentioned some literature she'd seen or studies people had been talking about in the hand world, trying to start looking at gender bias in kind of hand surgery in different ways, and we started kind of, brainstorming as a group. Oh, that's a very relevant topic right now. Is there something we could look at specifically in shoulder? And we kind of came up with the medium of arthroscopy as such a great way to kind of gender blind people and start to try to look at where there could be bias in evaluation, because it really just hasn't been done before.
So tell us, it sounds like working with a variety of different collaborators. Tell us how you got engaged, involved, and then how did you actually do this study?
Yeah, so I am fortunate. We have a pretty good infrastructure in place. Like I said, we have these meetings. Myself, my senior partner, senior author, Anand Murthy. We have these monthly meetings with the students and residents that are interested in shoulder and elbow research, and so we kind of work together as a group, and those the students and residents kind of gravitate towards projects that they think of, that they add to, that they want to be a part of, and so that's where our other authors came from. Jessica Hawken, she was one of our residents, and she had kind of brought some of the ideas forward. Charlotte Leap is an awesome medical student at Georgetown who kind of got really excited about the idea and had some good research background and started really running with it. And then Zoo was a statistician who was able to help us at Georgetown work through a lot of the data. And so to actually do it, we made the videos, and that was a collaborative effort with the group. We have a lab, fortunately, where we could do that. And then I really cannot credit Charlotte enough for the just really the drive she had in getting this study to completion. It was really a project that meant a lot to her, and she did a great job spearheading it.
So tell us about the mechanics of doing this. I mean, it sounded like you put together these videos. You had the videos kind of they're blinded, and then you attach names to them. Tell us kind of like the nitty gritty of how you got this done.
Yeah, so we went up to our lab. We made one video. We made the other video, and then we created the survey that we were going to send out that had the assessment of the videos. So the asset score, which is a way you can sort of standardized way to assess arthroscopic skills. It was a diagnostic shoulder arthroscopy. We wanted something that was straightforward and relatively short, so people wouldn't fatigue when viewing it. We thought of kind of some other questions we wanted to ask, just sort of demographics we wanted to get about our survey participants, and then we designed the survey. So we used, a survey design platform, and so we were able to set up the video that would be viewed first, followed by the questions and the assessment of the skills. And we were able to set up a survey that had the female name, and a survey that had the man's name. And then when people opened the link, there was actually a randomization built into the coding that would either give them the exact same video survey whole thing with a woman's name, and then or with a man's name. And that collected all of our data then too through that survey platform.
All right. Well, tell us. Oh, go ahead, Pete.
I was just going to make clear. So when you surveyed members, you didn't tell them we're studying gender bias. You just said
no.
We want to get your opinion as to the skill of these videos. Just so we're sure.
Yes, sorry, that is the critical part. And so we actually had pretty extensive conversations with our IRB at our institution about it because we were going to be deceiving the survey participants to some degree. The survey, we kept it general in terms of what we stated were our aims, that we were looking at, assessment of arthroscopic skills, which was true, but we did not include the part that we were looking specifically at how gender bias may affect the assessment of arthroscopic skills. And so we hoped to identify any kind of subconscious bias in that way. And then we did notify all the participants after kind of what we were looking at more specifically.
So tell us what we all want to know. What'd you find?
Well, we did not find any evidence of bias, gender bias, in the evaluation of arthroscopic skills in this study, which is, a really exciting finding on the one hand, because there was really no differences based on the name and the assumed gender of the trainee in terms of how the different evaluators rated them. And so that's, I think a really promising and exciting finding to see. But I also think it's, it comes with a caveat. This is one study. This is a small study. This is evaluating gender bias in one specific way. And so I think we have to be careful to not take the conclusions too far and say, well, there must never be any gender bias in evaluating orthopedic trainees, because I don't think we know that yet. But we do know, at least the way we kind of studied it here, and what we found, that it looks promising for the field, that we don't see it.
And one of the things you found that I think is interesting is and I just want to make sure I get this right, that participants in teaching roles, i.e., so if you were evaluating the videos and you were someone who usually worked with fellows or residents, that you were more likely to give negative comments than if you were someone who wasn't usually in a teaching role. Did I understand that finding correctly?
Yes, you did understand that correctly. And that was, I laugh a little bit because that was one of the things I thought was particularly interesting that kind of came out, because overall, like I said, we didn't see any differences in any of the ways we were trying to look for gender bias in the evaluation, either the ASES scores, the just other questions we asked people about, did they achieve their goals, that sort of thing. We didn't see any gender differences, but the only things that really came out were that we saw, as you said, those who worked with trainees were more likely to give negative comments, those specifically who worked with fellow trainees. And then when we kind of did the mixed effects model a little bit differently, we also saw that anyone who worked with trainees, like in a teaching role at all, they gave lower scores on the asset. And so kind of two different findings, but both suggestive of, I don't know if our teachers are being a little harder, or if those that don't work with trainees are being a little softer, but it was an interesting finding, to be sure.
Yeah, I think it's super interesting to think that the people who are in teaching roles, either there's a selection bias, those people are more critical, or maybe over time those people become more critical. But I think that if you're a resident listening to this, you can take heart knowing that generally the people of you are more critical than the average orthopedic surgeon.
Well, then I was wondering, maybe they're just more comfortable giving, criticism, we can call it, or feedback, right? So, those who are not in these teaching roles on a regular basis, they don't necessarily give people comments on their skills all the time, and they're not evaluating people regularly. So when, given the option, especially with the optional comments, when given the option to leave a comment on the person's skills, they may just not have had much to say. It's not a thing they do as much.
You just made a comment where you said criticism, but then corrected it to feedback. But I think that many of us, especially when we're trainees, we typically get constructive criticism in the form of feedback and rarely get positive feedback. Do you think, not necessarily related to this study, but what is your thought process on how gender or sex impacts the reception of criticism / feedback? Even me saying it out loud, I'm thinking the word really should be feedback, but often I interpret it as criticism. And criticism, it can be great. It's a great teaching tool, but not if you interpret it in a tough way. What are your thoughts on that?
Yeah, I think that's a great question. And, it was one of the things I thought we might see, even if we didn't see differences in The scoring, or kind of the overall, did they achieve their goal questions? I thought maybe in the comments, that would be where differences on gender lines came out. Did we see more positive towards the women and giving them positive reinforcement? Do we see more negative towards the women? Would we see something there? And we didn't. But this was a small sample, and I think in both how people give feedback to individuals, based on the trainees' gender, and then also how people receive feedback, there probably are some gender differences, although I think there's also a lot of individual differences. And that's where, to my mind, as somebody who works with students and residents and fellows, I think communication becomes so important, and just talking to each person that you're working with about how that's going to go and how feedback's going to go, to make sure everyone's on the same page, because there's just so much differences in how people kind of hear feedback and give feedback. Hopefully this is just the first of more studies like this, kind of looking at how bias may play into our trainee environment.
%. Well, I think that's, I think this study is going to open up a lot of eyes to the potential impact for gender in this regard, but the results show that it may not be as important. Is that kind of the take-home point for you?
Yeah, I think the take-home point for me is that we know, there's differences in there's a lot less women in orthopedics than men right now. And, we don't know all the reasons for that, and understanding how the trainee environment may differ for men and women, I think is an important part of understanding what we see as the difference in representation in practice. And so in order to try to close that gap, if that's our goal, which I think should be our goal, we just need to have a better understanding of any differences that are happening during training. So we didn't see anything in terms of what we looked at in this study, but continuing to make sure we understand that and evaluate it, I think, is important.
Well, thank you, Melissa, for coming on and talking about your study. It's a great study, and we congratulate you on it, and we'll look forward to the future of what you guys do next.
Awesome. Well, thank you guys so much for having me. We really appreciate the opportunity to share our work with you guys. We're really proud of it, and just happy to be here.
Yeah, thank you so much. We really appreciate it, and keep doing the good work that you're doing. Certainly leading the way for this area of research, but also mentoring and just being an all-around rock star. So thanks for doing what you do.
I'm here with Dr. Matthew Teeter of Western University in London, Ontario. Dr. Teeter is a collaborator with Dr. George Athwal on their study entitled "Are Short Press-Fit Stems Comparable to Standard-Length Cemented Stems in Reverse Torsion Arthroplasty, a Prospective Randomized Clinical Trial." Dr. Teeter, welcome to the podcast.
Thank you very much, and thank you for having me.
So we're just delighted to have you on to talk about this study. So tell us, what inspired you and your team to do this study?
Yeah, well, I'm an imaging scientist, focused on outcomes after total joint replacement, and using imaging as a quantitative tool to really measure what's going on inside the joints. And I've really spent most of my time looking at hip and knee replacements. But of course, we have a very active shoulder group, and Dr. Athwal is a fantastic surgeon here, and we kind of got to talking and say, can we kind of merge our worlds and apply some of our imaging tools to the shoulder population, knowing that reverse shoulders are so popular and there remain so many unanswered questions, and we thought this would be a great study to do.
So then tell us, you're an imaging scientist, tell us kind of more the nuts and bolts. How did you do this study?
Yeah, so the center of this study is used a tool called radiostereometric analysis, or RSA. So you guys in the shoulder worlds have taken over the RSA acronym for something else. We call this the RSA of RSA study, or RSA squared. But basically, RSA is a stereo X-ray technique. So 2 X-rays taken at the same time of the patient or the subject alongside a calibration box. which allows us to kind of recreate the 3D world inside the joint from those two X-ray views. An RSA can be used to measure joint contact kinematics. It can be used to measure polyethylene wear. But the one that's most well understood is for implant migration. So basically how the implant's moving in the bone over time. And for that, we put little marker beads inside the bone at the time of surgery, about 1 millimeter diameter tantalum beads around the implant. And then when we take these RSA image exams, basically we can then reconstruct the 3D world within the joint, and we register 3D CAD models of the implants into the X-rays, as well as find the location of the marker beads. And we can find out from sequential follow-up exams, in this case, starting at 6 weeks, followed by 3 months, 6 months, 1 year, 2 years, how those implants are migrating inside the bone relative to the bone beads over time, and basically measure the migration and kind of look at the pattern of that migration as well.
And so what did you find in that migration in this study?
So we examined cemented versus cementless humeral stems in a randomized design. And we hypothesized, based on behavior we've seen in hip replacements, that the cemented group would have greater initial fixation, so they would basically migrate less, whereas we'd expect more migration of the press fit or cementless group over time, but eventually achieving stability. And that's essentially exactly what we found. The cemented group moved a little bit, as all implants do, but really was stable from quite early on, whereas the cementless group or press fit group all sort of migrated up to 3 months or so before stabilizing, and had higher migration overall. As we also found one outlier that had much higher migration in that press fit group and might eventually become loose.
Interesting. So it sounds like there is some clinical implication. If there's enough translation, you think that maybe is a risk for loosening. Now, it's often said in shoulder surgery that it's a game of millimeters. So when you say there's a translation of 1 millimeter, that seems significant to me. How do you think this compares to implants elsewhere in the body? So like when you see a 1 millimeter change in a reverse implant, how does that compare to, say, what we see in a total knee or a total hip?
Yeah, so the nice thing with RSA for hips and knees is that there's been so many trials done over the years that we have really good data from meta-analyses. We actually have set thresholds for implant migration to kind of know if we can predict loosening. So, if more than a 0.5 millimeter migration in a total knee over the first 6 months, we start saying is at risk, and more than 1.6 millimeters we say is really unacceptable. And then we also have thresholds sort of based over time, where if implant between 1 year and 2 years has moved more than 0.2 millimeters, we actually call that continuous migration, and we think it's basically loose, and there's a good chance of needing revision. And in fact, we know from studies that above these thresholds, you end up getting more than 80% likelihood of needing revision at 5 or 10 years. So it doesn't seem like very much in terms of if we're talking about a 0.5 millimeter or less of migration. But if it's happening at the wrong time point, it can really suggest that the implant is still loose and keeps moving. And in our one outlier case here that actually moved more than 4 millimeters over 2 years, the patient actually had quite a lot of pain and had worse PROM scores than other patients. So it does maybe tie together some of the clinical presentation that you guys might see in your clinic with patient with pain, with what might be happening inside the joint with the implant continuing to move inside the bone.
Now, I think one of the big comparators here is cement versus no cement. As I'm sure you're aware, there's been a big movement away from cement, certainly in the United States. I think it's somewhat based on time, but also based upon the challenge of revision of fully cemented implants. Do you think that this study really supports cementation in the shoulder world, or do you think that this means we just need to do a better job with our cementless fixation?
Well, it's a really interesting topic, and for someone like myself who's not a shoulder surgeon or a hip surgeon or a knee surgeon, looking across all these specialties, everyone's kind of moving in similar directions. And what was interesting about this study was that based on data we've seen from hips and knees, we actually expected a little bit more earlier migration followed by stabilization of the cementless group, which is what we found. So that sort of tells me that all these implants kind of have the same pattern or what you'd expect, kind of how the bone works working with an implant. So I think there are substantial advantages to a cementless implant long term if you can achieve good bone ingrowth, not just for the surgery itself, but we've seen RSA data in total knees, for example, where at 10 years, there is less inducible displacement of a cementless implant versus a cemented implant. And what that means is doing RSA studies, not over time, but comparing between an unloaded and loaded exam at the same time point, basically trying to make the implant move. It seemed that the cementless implants were more well fixed at long term. So it does seem that there's an advantage if you think that the patient has good enough bone quality that they could take a cementless implant that actually might be better for them in the long term. But you do have to, understand that the implants might behave a little bit differently earlier on. Like you may see some initial migration over time and some maybe changes on your radiographs, which might be a little bit concerning. But I think as long as the implant does achieve stability, then you've kind of achieved the goal, and that's a good option. But I also understand it can be difficult to predict from patient to patient whether the bone quality would be good enough. And in some cases, you kind of default to cement based on an age cutoff or something like that.
Dr. Teeter, you alluded to a lot of this just now in terms of potentially preferring cementless implants in the future. How do you think this study overall is going to change our practice, particularly for maybe current residents and fellows who are going to start out in the next couple of years? What should they take away from this in terms of planning their implants or planning their prosthetic designs? What do you think?
Well, there's a few things. I mean, number one, it's one study of 41 subjects. You know, it's a thing with RSA. It's so precise, you don't need so many subjects. But talking about things like bone ingrowth, there's a lot of patient-specific variability that we might not have covered within the people we recruited for this study. And if the surgeon, that was one of our exclusion criteria, where if the surgeon expected there would be really poor bone quality, they weren't included in the study. So I think you still have to be careful about who you're selecting for a cementless implant. I think this helps set a baseline and kind of get some data out there in terms of RSA data for shoulder surgery. And I'm hoping more centers will come online and do similar studies looking at the different kinds of implants that are available on the market, because they don't all behave exactly the same, even though you think they might be very similar. Sometimes we've seen that with other joints where, there just ends up being some bad implants for whatever reason. But I think it is promising. It shows it's a good option. Maybe think about cementless as maybe a default, unless there's some good reason to go to cemented if you're comfortable with doing that. But there's a whole other aspect to this too, which we should think about. We're talking about was half millimeter or millimeter, is that clinically significant? There's such a great focus now on navigation and robotics and trying to achieve a target. But thinking about how the implants might move away from, what you did at the time of surgery, migrating in the bone, is the patient ending up with the reconstructed joint you did at the time of surgery, or, if things are moving more, you're getting away from that. So that's an aspect that's not really been thought a lot about even in the RSA world, because we think more about just fixation period. But in terms of all the total restoration and biomechanics of the joint, that's another thing we should be thinking about, talking about future technologies and things like that. Kind of what's the balance there in terms of achieving that early fixation and long-term fixation, then also ensuring, the implant's kind of staying where you put it at time of surgery, because you're trying to optimize for the patient.
Awesome. And then any final take-homes from the study that we didn't cover today during this podcast? Any last, take-home points for our listeners and for the readers of this article?
Well, I would encourage everyone, if they're talking to the companies or regulators, to start asking, can we get some RSA data for new implants, or, kind of get quantitative measurements as opposed to just following X-rays over time, which maybe not give you the exact truth about what's going on. I mean, certainly we saw some radiographic changes with implants that migrated but then became stable, and, it might give you the wrong impression about whether the implant's actively loose or not. So it is something where, we want to have a good understanding about what's going on inside the joint. And as a researcher, I always say that, more research is a good idea, especially as new technologies are coming out. So I hope it becomes an active area that's followed, and, we can really understand how different implant designs and technologies are coming along and what they're going to do for patients.
Awesome. Well, thank you so much. That unfortunately is all the time we have for this podcast, but we want to thank you for coming on and sharing your work with us and for the listeners. And for all of our shoulder and elbow listeners out there, please don't forget to subscribe. And for Pete Chalmers, I'm Rachel Frank, and we'll see you next time.